Yeah, dear David, thank you for that nice introduction. Dear friends from the ITI network, it's a pleasure to share with you some of our ideas on narrow diameter implants. And you ask yourself, this is a maxillofacial surgeon. Why is he talking about narrow diameter implants? He should talk about bone grafting procedures. But I think there are many indications where we have narrow diameter implants in our mind. It starts already with the mesiodistal aspect. Let's say the simplest positioning rule, when we combine a premolar and a molar implant and we think, okay, this is a good indication for a narrow diameter implant. But the more interesting one, and we heard a lot about this one today, is the buccolingual aspect. We heard that there should be about 1 millimeter of natural bone, biologically valuable bone on the implant. Is this figure anyhow fixed? Does it come from the literature? So it's a questionable figure. We have in our clinical experience there should be enough bone on the implant, but the figure itself is unclear. But I think we all agree that bone around the implant is important. So that's the second step where narrow diameter implants might come into our mind. And when we think of the indication, which is the most challenging indication, where we would think, should we do a bone graft or should we do a narrow diameter implant? Of course, that is the lateral mandible. Here the bone augmentation procedures are sometimes more critical, and we have patients who say, a dental implant is fine for me, but bone grafting, no way. So these are follow-up cases where we already did with the standard implant a molar reconstruction, which is challenging and which is out of the indication. You have to talk about your patients about that. And of course, there are patients who are medically compromised. Think of that patient. He is under anticoagulants with aspirin on clopidogrel. You would do dental implants there. But would you do a bone grafting procedures? So we combined here with a typical removable German double crown denture, the restoration for these patients. And the other group of patients are patients under oral bisphosphonates. Of course you can do dental implants here, but would you do a major bone grafting procedure in the lateral mandible? So narrow dental implants open up the indications for patients who would not be able to have a restoration. We have patients with maxillary cancer. Here we do the immediate implantation during the resection, and when they go to the radiation process, then the osseointegration already took place. Patient under oral bisphosphonates, as I already told, narrow lateral ridge in the mandible, and here you would not do a bone grafting procedure, but you would do the dental implant. So the first question, which relates very close to the next speaker with the short implants, is overloading possible? Don't we need a large area of bone implant contact? Of course, there's no clinical study in that. There's a nice review from 2012. You will not find a randomized study comparing overloaded and classically loaded implants. But we have good animal data on that. And when you look at the animal experiments like this one, you see that when implants are highly loaded, what will happen? Of course, the bone reacts. You will have more bone. It's an anabolic effect on the implant. The problem is when an infection occurs, then you have larger bone loss around overloaded implants. I think we should have this in mind when we think of narrow diameter implants, especially in the molar area. We had the discussion at the German conference. There were people complaining, why do you talk about stronger implants? I never saw any fracture. These fractures happen. Different fracture types, all below the screw, seen at our department. Keep in mind the indication. These are all shortened ridges in the molar area. We should come back to this point later on. But when we think which structure of the implant is the one which carries the most load, especially when we think of a bone level implant, of course this is the superconstruction and the abutment. So there's a nice work, it's in vitro from the Hannover group, and they looked at the tensile forces after mechanical loading of these abutments, and you see that after mechanical loading, the tensile forces go down. So we should think of the design and the mechanical stability also of our superconstruction. Nobody talks about this a lot. So when we reduce the diameter of our implants, especially in the molar region, we have to talk about our patients about possibly more technical complications. As you see here, a fracture in the abutment screw, fracture in the abutment, and fracture at the implant level, screw loosening. So technical problems might happen, and that restricts already our group of patients who can receive narrow diameter implants. We had the pleasure of the Consensus Conference of the ITI, and one topic was narrow diameter implants. And we took together all the evidence from the literature, and I want to share this with you today. So first thing is, we should not put narrow diameter implants into one basket and compare them all. There's one very critical group, controversially discussed in the literature, and these were the so-called mini implants. They are made of titanium alloys, titanium, aluminium, vanadium. They are single piece, usually immediately loaded, and you see this is a case done by the head of our department, Professor Wagner. We use them, but we use them in an open flap procedure, especially in this indication with a narrow ridge, and there is literature on that. So when you look at the 3-point or less than 3-point millimeter mini implants, in the literature you find more than 3,500 documented implants there, which is quite a lot. So we cannot ignore that. And one of the nicer publications is here from an Egyptian group. They looked at the edentulous mandible. Again, you see 4 mini implants, 3 years of follow-up, but look at the success and the survival rates. You have 93% success rate after 3 years in this rather simple indication. So we have to keep in mind this is not as reliable as we know this from our 2-piece implants, but we cannot ignore these evidences. And what we also know from the literature, the mandible seems to work, but in the maxilla, there seems to be a rather critical therapy option. A case from our department who received from another dentist 4 mini implants on the maxilla, and you saw what happened there after the loading procedure. So that was too much. So the consensus statement, you can tell 1.8 to 2.9 mini implants. The survival rate in the literature was about 94%. The mean follow-up time is rather high, with 4 years, and the indications are very restricted to 4 implants carrying an overdenture in the mandible and the lateral incisor, the so-called non-load-bearing teeth. Quite interesting to have these rather small group of implants. There's another very interesting group of implants which is on the market for a few years only, and these are the 2-piece, but about 3.0 millimeter implants, which are designed for the anterior teeth. They are not to be mixed up with the 3.3 to 3.5, what we call narrow diameter implants, which we would use also in the molar or premolar area. So we should look at these two groups separately. So when you look at the literature, there are lesser implants documented in the 3.0 group. They have been introduced recently. Many of the manufacturers have no studies at all on their implants, only 600. I want to show you one example, and here you see in which indication they use it. It's the lateral incisor, and usually it is the aplasia, the large group of patients who receive these 3.0 implants. So the ITI consensus statement puts it together. We have a high survival rate of these implants, but only few cases, 3 years follow-up time, and it's only a single non-load-bearing incisor. But let's switch to the more interesting group of implants, the 3.3 to 3.5. And here you see we have a quite high number of documented implants in the literature of the so-called narrow diameter, and I found a new one which was quite interesting. They looked at 3.3 Straumann implant and 4.1 millimeter Straumann implants in the lateral area and looked at the bone level. And they concluded that the 4.1 are advantages regarding the bone remodeling. You see the bone remodeling of the 3.3, and the bone remodeling at the 4.1 implant, do you see a clinically relevant difference? It might be statistically nice to see the difference, but from the clinical point of view, these seems to behave the same. And what I found was a kind of eye-opening publication, especially on the molar area, comes here from Paul Malot. He used a reduced diameter implants, but look at the implant abutment connection. He used an external implant abutment connection. So this becomes more critical there. And the multivariate analysis shows very interesting things. Look at the odds ratio for implant failure in partial bridge compared to single teeth. And when you think back of our fractures, the partial bridges seem to be much more critical than the single standing teeth. Of course, this is clear from the clinical point of view, but it's also shown in the literature. And also the surgeon's experience is very interesting. Only the very experienced surgeon is able to reduce the risk of implant failure. So you will not be able to use a narrow diameter implant and turn a critical case, a complicated one, in a simple one. It still is a complicated case. So quite interesting and a lot to learn from this publication. So in this group, 3.3 to 3.5, we have rather high survival rates, long documentation times, and in the literature you find a lot of indications, also including the posterior region, we have to admit. In the ITI, of course, we are very conservative. We had to admit there is a risk of bias in these narrow diameter implant studies. There are no comparative studies. There are no really long-term studies. When would you expect a fracture to happen? Not after 3 years. It would happen after 10 years. So there is risk of bias. And if we go back, there is also an unanswered question to a prosthodontist. Should we splint the crowns on these narrow diameter implants, or should we use them in a single? And if you look at the soft tissue, the narrow band of keratinized soft tissue, that is also a very important aspect. Should we use transgingival healing here, or should we use a straight approach? So we often use a transgingival healing and like the soft tissue level implants because we can organize the soft tissue around these implants. So it's not only the bone you should look at, you should also look at the soft tissue in these critical situations. So the ITI guidelines come together that the positioning rules are still very important when you deal with narrow diameter implants. They still are of values. Narrow diameter implants have several indications, but you should be aware of the biomechanical problems. Talk to your patients about that. And then, that's the very conservative aspect, we said the implant diameter should be the widest possible in relation to the ridge configuration and the emergence profile. Does this mean we have always to use a 4.8 if it's possible? I think there's a little question mark behind there also. And what is very important, you should not mix the length of the implant with its diameter. So usually in the studies, all of these narrow diameter implants, they are 10 millimeters or more of length. So please don't mix the length and the diameter by reducing all. If we look at the internal evidence, so what are we doing in Mainz? When we look at our implant database, we just looking at focusing at the molar areas, you see that most of the implants we're using in the molar areas are about 4 millimeters of diameters coming from different brands. And at least in the retrospective view, there's no difference in the failure rate of these. So when you go home now and you have to have a molar implant for yourself, would you choose the one with a wider diameter on the left side? Or would you choose the one on the right side with a smaller diameter? I think you should think for yourself. But times change, as we heard, and implant stability is getting better with the Roxolid implant material. So already the cold welded titanium, the middle bar was quite strong, but we have an increase in the tensile strength with the Roxolid alloy. And for me it was very impressive how Straumann approached the market with his new materials, starting with animal models, and all these animal models tend to the same direction, to have at least the same osseointegration like we know from the standard titanium. That is very, very impressive, and the first study in human was done in a very conservative approach. splinting a standard diameter and a Roxolid reduced diameter implant together, done by Stephen Barter, with promising results. They had one failure, which I think is, for a clinical study, understandable, and we already have 2 years follow-up from these early data. And then something important happened. Imagine a manufacturer which you are approaching and you ask him, we want to compare your old product and the new one. We want to compare this double-blinded. Would you do this? Do you find a manufacturer doing this? We're quite happy to have that study design, a split-mouth, randomized, double-blind study. One side was a Roxolid implant and one side was a standard titanium implant. And the data after 1 year showed that we have one success in the Roxolid, one failure in the Roxolid group and one failure in the titanium group. So similar results after 1 year. And also this multi-center trial is now available with a 3-year follow-up. And again, it's interesting to see how will the bone level implant behave. And you see that more than 50% of these implants in the, of course, rather easy situation of the mandible, they have a bone remodeling of less than 1 millimeter, which I would regard as perfect bone. When you have a new material on the market, you don't want to restrict it to an easy situation like the mandible, which is edentulous and carries no loading. There is the non-interventional study running, which is open to every indication. And of course, it's interesting to see in which indication has the Roxolid implant been used. You see that there are more than 600 implants in the non-interventional open study, and we have a survival rate there high above 97%, which is fine in the open indication. And you still see here the question of the premolar area and the mandible. We have the thin bone above the narrow diameter implant. Would you like to augment this and use a larger one, or would you use a narrow diameter implant? And when you look at the failure rates in the molar area, we don't have higher failure rates than in the front. What about the bone level changes? What we expect. Most of the implants, about 80%, have about no bone remodeling or bone level changes. But the most interesting question, of course, is, would you change your therapy concept using a narrow diameter implant? And the question was, would augmentation be necessary with an implant diameter larger than 3.3? And this was a yes in more than 50%. So there is the option to change our ideas of the therapy concept. So a typical combination at our department, especially in the edentulous maxilla, where we combine narrow diameter implants and standard diameter implants in a classical procedure, working with a soft tissue a little bit, and the German double crowns with a removable denture and a happy patient. So still there are open questions. We know that narrow diameter implants are working, and we know that augmentations are working, but we have no comparative studies. Which direction would you go, especially in the edentulous mandible? So I still wait for the study comparing augmentation with a standard diameter implant and the narrow diameter implants on the long run. And you can choose yourself which way you would go when you would have an implant for yourself in the lateral mandible. So let's make a little game. We have the bucco-oral or bucco-lingual distance of about 6 millimeters. A lot of bone. Would you do a 4.1 with a little bone grafting? Of course, Geistlich would be happy. Would you do a narrow diameter implant, 3.3 in this situation with a molar? So there's a classical TE, large diameter. Of course, a lot of stability there. Or the indication, as we already saw, with a narrow neck CrossFit implant, also a quite nice situation. So you can think of yourself, and I think it should not be our own idea of what treatment option we choose. We should involve the patient. So when we come to the conclusion, we have to say, reducing diameter of the implant, hardware becomes important. Not only the implant itself, but also the abutment and the screw. Roxolid is now documented for 7 years. We can say it is safe and it offers a lot of new possibilities for us. When we think of the diameter, please don't mix narrow diameter implants together. We have the mini implants only for the edentulous mandible and the single incisor. We have the 3.0 only for the single incisor, very restricted in their indications. And we can say the 3.3 to 3.5 are open for all indications now, especially with the Roxolid. Augmentation still is an alternative, and you should inform your patients about both options and find the best solution for your individual patient. And with these ideas, I hope to keep you thinking a little bit about the implant diameter next time when you do a dental implant in the lateral region. Thank you very much for your patience.